timer, and here is your question. Right, so if you've read and understood, considering it procedural skill station, kindly begin now.
Hello, yes. I will see.
Yes, you'll
Yes.
read and you'll enter, and then
Okay, yes, I will read and enter, and then I will introduce myself. Hello, I am
yes,
Dr. Muhammad,
yes,
the treating doctor of today. May I confirm name and age, please?
yes. Tiffany, 53 years old.
Okay, today I have been asked to to incise the wound in your thigh, and to drainage the wound inside. This will be under anesthesia. And you may feel a little pain, and after that we will have some instruction after that. Are you okay with that?
Yes,
Okay, so I will check that this is. Do you have any allergy to Lidocaine or any other?
no,
Okay, I will check this is the right person, and this is the right patient, and this is the right side in here in the leg, and this is the right procedures from the note. Then I will start by asking the patients. Now I will do you feel any pain at the moment?
it's tolerable. You can go ahead.
Okay, and I will incise. I will give Lidocaine around the abscess. Then then I will start by and then I will incise the abscess by elliptical or vertical incision. Then I will drain by start. I will remove any from the discharge by using drapes and by pressure on the side. Then I will by my little finger irrigate, move inside the abscess, and to remove any locules and to block any locules. Then I will start irrigation by saline. After that, I will put an allignate back and trimmed it so that to be short to prevent any macerations around the skin. Then I will put an aquacell dress and give instructions to the patients. Now I finished. You will need to change the dressing every day, and the alginate bag will be removed after 3 to 4 days. And I will prescribe you, and I will prescribe the patient antibiotic according to the trust of the trust policy of the hospital. May give him one dose of coamoxiclav broad spectrum before going to incision of drainage, and then thanks the patient and ask him. And before, sorry, I forget that I should take the swab for culture. before start at the first iron size, and I will tell the patient that the result of the result of that of the cultures will be within 2 weeks, and I will inform you once available.
Are you finished? Okay, can you please tell me what is the maximum safe dose of this local anesthetic that you can give?
Yes, Lidocaine is maximum is 3 milligram, 3 milligram, or
Do you know how to calculate the dose for this particular patient who's just say 65 kg of weight?
65?
Yes, just suppose.
Yes, 3 milligram per kg. So 3 multiple.
So you are calculating the dose of lidocaine or bupivacaine?
Bupivacaine is
All
2
right.
mil.
Okay. Yes.
Bupivacaine is 2 milligram per kg,
Yes.
and the maximum dose is 7 milligram of 0.25 percentage.
Yes.
And
with or without adrenaline, how much it would be with adrenaline?
Not given with adrenaline. Without it is the same 2 milligram, not given with adrenaline. While the lidocaine
should you give adrenaline when you are doing incision and drainage in the leg?
No,
okay, good. Why?
Because the end artery it may cause.
Very good. Can you please tell me what influences the potency of anesthetic?
What?
Potency of anesthetic. What influences?
Influences the potency of anesthetic?
Yes, please. It depends on dose and lipid solubility. Okay.
Yes, dose and level.
Yes. What influences the duration of action of a local anesthetic?
Local of action of local anesthetic?
Yes, please.
Half an hour to an hour.
No, it's related to the degree of protein binding, vascularity, and
degree. Okay.
All right. Okay. Can you please tell me what influences the cardiotoxicity of the local anesthetic?
Cardiac toxicity, also the dose and the type, and if the patient is allergic or not.
Which one is less cardiotoxic, lidocaine or bupivacaine?
Lidocaine.
Yes, good. Okay, why do certain local anesthetics have a quicker onset of action than others?
Why has a quicker onset of action?
Yes, than others. Why certain local anesthetics have quicker onset of action than others?
Can we conduct this question later?
All right. Okay, what is the mechanism of action of local anesthetic?
Yes, cause the block sodium channels by and depolarization and blocking sodium channel.
And interruption of neuronal transmission. Okay, yes. How would local anesthetics toxicity present? What are the signs and symptoms?
Yes, maybe anaphylaxis, shock, and the patient there is maybe redness, hotness at the site, swelling,
tingling, paresthesia.
Yes, tingling, paresthesia, maybe tachycardia, okay. or hypertension.
How would you manage the toxicity of local anesthetic?
First, I will call for help, and I will stop as anesthesia, giving more anesthesia, and yes. Cancel the procedures. And I will deal by the patient according to the symptom and to the symptoms, and according to the anesthesia. I will first I will if the patient is tachycardiac, and I will give him atropine, and I will and give the antidote later. I will give the antidote of the analgesic. All right, you manage it according to ABC approach. Yes, Chris. Yes, very good. This is what I wanted to hear. Okay. Bolus of what would you give? What? A bolus of what? Antidote, you said. Antidote for what?
Local anesthetic we are talking about.
According to the type of anesthetic,
Intralipid is for what?
intralipid,
Yes, it's the commonly used drug.
intralipid. No, I can't. I don't know.
Okay. All right. All right. Now we'll consider, thank you so much,
Okay.
how you did everything and on what points your marks will be given. Okay, first is awareness of indication of local use of local anesthetic. So you asked the patient about allergy, so that is good. So that means you knew why local anesthetic is being given, or and also aware of classes of local anesthetic. So you should be known which class of local anesthetic you are using. If you know, then 2 points are given for these two questions. So 4 points there. Then if you understand the mechanism of action of a local anesthetics, then again 2 points will be given to you, right? And if you are able to name the 3 local anesthetics, all 3, which can be used, then you will be given 2 marks. If you are able to name 1 long-acting local anesthetic, you will be given 1 mark. If you are aware of the additives like adrenaline, when to give and when to not to give, and how much will be the dose difference, then you'll be given 1 mark. If you'll tell the safe dose of lidocaine with and without, you'll be given 2 marks. If you are able to calculate the appropriate maximum dose of the patient, you'll be given 2 marks. If you are aware of the complications of the local anesthetic, you'll be given 2 marks. If you are aware of the presenting symptoms of the toxicity of the local anesthetic, you'll be given 2 marks. If you are able to state safe management of local anesthetic toxicity, you'll be given 2 marks. So that was the point distribution. So some of the questions, some of the points you have missed, but once you'll go back and read, then you will tell. You'll learn definitely. Okay. So if you're adding adrenaline, so it is 1:2. How much is the dose that you have to add?
7 milligram per kg.
Yeah, for which?
For the lidocaine and for the bupivacaine is the same too.
Yeah. Good. This you know. Good. Yeah, right. So that was it. Thank you.
Thank you.
Right. And started the timer, and here is the question. Oh, sorry, I have given you, I'm sorry. Here. No, I'm sorry, that was for right. So if you have read and understood, considering it surgical anesthesia, kindly tell me what are the boundaries of popliteal fossa first?
The popliteal fossa, it is bounded superolaterally by the byssus femoris, superomedially by the semimembranosus and semitendinosus, inferior-laterally by lateral head of gastrocnemius, inferior-medially by middle head of gastrocnemius.
Good. What are the contents from superficial to deep of the popliteal fossa?
From superficial to deep, it is the tibial and common peroneal nerve, then popliteal vein, popliteal artery.
In the lymph node. Okay, if
And
there
the
is
lymph
a
nodes.
swelling in the popliteal fossa, What are the differential diagnoses that you'll consider?
The main differentials for swelling or lump in popliteal fossa will be Baker cyst,
Yes.
aneurysm of popliteal artery,
Yes.
varicosities of popliteal vein, schwannoma or neuroma
Yes.
of the nerve, lipoma.
Very good. Okay, can you look at the picture on the left-hand side and identify the structures A, B, and C and D, please? What is A pointing at?
A is the tuberosity.
And B is what?
B tibialis anterior,
C, please.
medial malleolus.
D, please.
D is posterior tibial tendon.
All right, if you can please
Tibialis
tell me
posterior.
the diagram that you're looking at on the right-hand side and identify all A to D marked structures, please.
A is the popliteal artery, B is the intertibial, C is the posterior tibial, and D is the peroneal artery.
All right, can you please tell me how many compartments there are in the leg and how are they divided?
In leg, mainly there are 3 compartments, and in the posterior compartment there are superficial and deep, which makes total 4 compartments.
Yes.
The 3 compartments are anterior, lateral, and posterior, and the posterior compartment are divided into superficial and deep. Anterior and posterior compartment are divided by intraosseous membrane. Anterior and lateral compartment is separated by anterior intramuscular septum.
Yes.
Lateral and posterior is separated by posterior intramuscular septum, and in the posterior compartment, superficial and deep is separated by transverse intramuscular septum.
Can you please tell me the surface anatomy or the course of the sciatic nerve?
Sciatic nerve, it begins from below the piriformis muscle, and then it proceeds, it runs down on the posterior aspect of the thigh, and it terminates at the apex of the popliteal fossa and divides into common peroneal and tibial nerve.
Not quite. Okay, but can you tell me the surface marking of it? Where would you be able to?
Sciatic nerve, it is a curved line that joins
Yes.
2 points. One
Yes.
point is between the posterior suprailiac spine and the
Yes.
ischial tuberosity, and another line between the greater trochanter and the ischial tuberosity.
Can you please tell me the variations that you know of the sciatic nerve exiting the pelvis?
There are mainly 2 variations. One is where the common femoral nerve pierces the piriformis muscle.
Yes.
And the other one is where the common peroneal nerve arises from above the piriformis muscle.
Is there any other variation? Any third one?
Others.
Okay. Can you please tell me what are the nerves which are related to anterior iliac spine?
Anterior suprailiac spine. The nerve is the lateral cutaneous nerve of thigh.
Yes. Entrapment of this nerve is called what?
It causes a syndrome called meningeal paresthetica.
Yes.
Which presents as a painful condition.
Yes.
Due to the entrapment.
Where?
Of
this nerve?
Behind the inguinal ligament.
When it passes through the inguinal ligament. Yes.
Inguinal ligament.
All right, good. Thank you. Okay, can you please name the muscles of the anterior compartment of the leg?
There are mainly 4 muscles. The tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius.
Okay. In this case, patient could have had compartment syndrome. What is compartment syndrome?
Compartment syndrome is a condition where there's increased pressure in a intercompartment.
What is the
increased
normal
pressure?
intra-interstitial pressure?
It's 5 to 15 millimeter of mercury.
You read that. Okay. In this case, if you are reading, what do you think or what do you suspect? Which compartment can have the compartment syndrome, considering the history of the patient? And how would you confirm? Okay, pass, you'll tell me at the end. Can you please tell me what type of joint is the popliteal joint, knee joint?
Knee joint is a synovial type, a hinge type of synovial joint.
What are the movements which are present at the knee joint?
Knee joint, there are mainly two movements, flexion and extension.
Are you sure? Okay, what stabilizes the knee joint? Can you tell me all the structures which stabilizes the knee joint?
This one, pass now.
Okay, can you please tell me how would you or what are the knee reflexes? How would you confirm the knee reflex, or how would you check for the knee reflex?
We have to ask the patient to relax his leg without the feet touching the floor, and
Okay.
and it should be flexed around 90 degrees, and it
Yes.
should be supported with our hand. Then we'll tap with the percussion hammer on the patellar tendon and see for
You'll pat on
contraction
where would you tap the hammer?
on
And
the
you'll
patellar tendon.
And
See for
contraction.
contraction of the quadriceps muscle.
Very good. Okay. With this knee reflex, what nerve roots are being checked or confirmed?
Number 3 and 4.
Yes, that's good. All right. In the posterior compartment of the leg, what are the muscles which are in the superficial posterior compartment, and what are the muscles of the deep posterior compartment? Can you please tell me?
Now, posterior we have 3 and deep we have 3. Posterior is superficial with gastrocnemius, soleus, and plantaris.
Yes.
And in the deep we have 4.
Yes.
Tibialis posterior, flexor digitorum longus, flexor hallucis longus, and popliteal.
All right, good. What motor and sensory function is lost when there is a damage to the superficial peroneal nerve?
There is loss of eversion, and there is loss of sensory innervation over the dorsum of the foot.
Okay, good. Let us go on.
Okay,
Yes, that you'll tell me, how would you recognize which compartment syndrome, which compartment has, has the compartment syndrome in the lower leg? Right.
Mid-tibia,
Good,
I think
you.
anterior.
Sorry?
Is it anterior compartment?
Yes, but how would you confirm? What would you ask the patient to do?
We have to do passive extension, passive plantar flexion of the ankle joint, which extends the anterior compartment muscle, and there will be severe pain.
Yes. And that's your clinical confirmation. Okay, good. Thank you. So A is tibial prominence, B is fascia. This is the yellow, you can see it's the fascia overlying tibialis anterior muscle. So it's not muscle, it's not nerve, it's yellow, so it's the fascia overlying tibialis anterior. C here is the superior extensor retinaculum. This is the retinaculum here. I'll
Yes.
maybe show you a bigger picture so that it will be more clear. In exam, they'll give you clear pictures, so no need to worry. D is fibularis longus and brevis tendon. So these are the two tendons.
Okay. So here is the lateral malleolus, right? This is
Yes.
the lateral, not the distal. Okay.
This is medial malleolus or the lateral, sorry, lateral malleolus.
Yes.
Yes, that's why it's the fibulus.
So A is the
tibial prominence.
tibial prominence. Okay.
Yes, tibial prominence. And this is the fascia overlying the tibialis anterior, and this is the superior extensor retinaculum. And these are the fibularis longus and brevis tendon.
Okay.
And here, if you can please tell me, A is right popliteal artery, discussed that yesterday. B is the right anterior tibial artery. And then C is the right posterior tibial artery. And then D is the right peroneal artery.
Yes, common.
Yes. We discussed this yesterday. Okay, this was the lateral. Okay, if you have to tell me the structures passing through the medial malleolus from anterior to posterior, can you tell me?
Behind the medial malleolus?
Yes. Tibialis
Yes.
posterior and
Yes, tibialis posterior, posterior tibial artery, posterior tibial vein, and tendon of, and also flexor hallucis longus,
and
flexor digitorum longus.
Longus, very good. This you know. So good. Thank you. Started, and here is your question. Right. So if you've read and understood, considering it clinical examination station, kindly begin.
Yes, I will welcome the examiner first. Hello, sir, and then I welcome the patient. Hello, I am Dr. Muhammad, one of the surgical doctor. May I confirm name and age, please?
Yes, I'm Luisa, 23 years old.
Nice to meet you, Mrs. Louisa. Today, I've been asked to examine your shoulders. This may include looking, feeling, doing some special tests. Are you okay with that?
Yes.
Do you feel any pain at the moment?
No.
Okay, please, if you feel any pain, tell me. I will offer for the exam after washing my hand. I will offer the examiner that in the same the patient has a pain in the right shoulder. So may I start with another one, and then I will start examination by I start by examination by looking at the shoulder from anterior for any from any muscle wasting, any scars, any prominent of the clavicle or the acromion or any bone deformity, and then start looking for at the side for any deltoid muscle wasting, also any scars. Looking for the back, then I will look for the back for any deformity, any winging of the scapula, any prominent spine of the scapula, or any scoliosis, or any scars, or any swelling. Then I will start by feeling. First, I will ask the patient again if any pain. I will start now. I will start feeling I will start first the temperature by the back of my hand,
Good,
and
good.
compare to the other side at mainly at the from medial end of clavicle and all the clavicle and the shoulder and the back to the spine of the scapula. Then I will start feeling for any tenderness, starting by the sternal end of the clavicle and all the clavicles, then the acromioclavicular joint, acromioclavicular joint, then the shoulder and the spine of the scapula and all the border of the scapula. After feeling, now I will go for movement. I will ask the patient to do a forward flexion upward, and then extension backward, and abduction, and adduction. The adduction is the adduction. Then as adduction is examined by the patient putting his and then internal rotation and the external rotation can be doing passively, doing actively. The patient putting his hand 90 degrees beside his sides and move it outwards. This is external rotation, and then internal rotation by the patient touching his back to the upper. To the highest point he can do it. Then I will do passively only the flexion and the extension and the adduction and abduction.
Yes.
Okay, then I will start testing, doing special test. I will test the muscles first, the supraspinatus, by empty can test. The patient will point his thumb downwards like empty can, and it's around 30-degree flexion. And ask the patient to elevate his arm against my hand, against the resistance. Then I will test for the infraspinatus and the teres minor by the patient put his hand 90 degrees beside in his side, and ask the patient to move his hand outwards against resistance. Then for the subscapularis, I will ask the patient, we will do the Gerber Liftoff test. The patient will touch his back and push against my hand. And if there is severe osteoarthritis, we can do a Napoleon belly press test. The patient put his hand on his tummy, and I will push against the elbow. Then I will test for another muscles like serratus anterior by pushing against the wall. It's if it is injured, there will be winging of the scapula, and also trapezius by shrugging of shoulder, and the biceps muscles by speed test, by flexion against resistance, or Yergeson test by doing supination against resistance. Then I will test for the subacromial impingement test by doing near test, which is internal rotation. By the patient hand is extended, the patient arm and the forearm is extended, and I will do internal rotation, and the other is Hawking internal rotation, and the hand is 90 degree and 90 degree. And then for the acromioclavicular joint, I will do O'Brien test. For the forearm and arm is 90 degree, is 180 degree in the front of the patient, and thumb down, and then push against in his hand if there is pain. So this is the acromioclavicular joint pathology, and if there is thumb up and there is pain, so it is labral tear. And the last one is the scarf test. The patient doing his hand like a scarf, and I will push his hands. If there is pain, there will be acromioclavicular joint pathology.
Good. Okay, can you present your case now?
Yes, today I have examined shoulder joint of Miss Lisa, 23 years old.
Yes.
Yes, Miss Lisa, 23 years old, presented with right shoulder pain. On inspection, there is no swelling, no swelling, no scars, no prominent bone, no deformity, no muscle wasting, no spine deformity, and no winging of the scapula. on feeling her joint, there is equal temperature on both sides. There is tenderness on the right shoulder joint at the cronoclavicular joint, and on assessing the movement, there is limited movement in the right shoulder joint, especially at external rotation and abduction.
So what are your differential diagnosis?
So my main differential diagnosis may be subacromial impingement or labral tear, or a trauma or direct trauma, or maybe bursitis.
How would you confirm your diagnosis?
I'll confirm the diagnosis firstly by doing a routine plain X-ray of the shoulder, AB and lateral, to exclude any bone injury. Then I will do MRI to confirm the diagnosis for any ligamentous tear or labral tear or any bursitis, and start the treatment first conservative by physiotherapy and non-steroidal anti-inflammatory drugs, and physiotherapy. And if there is a labral tear or no response to medical treatment, I will do laparoscopy.
All right. You'll advise the patient for rehabilitation for how long?
Rehabilitation for 3 months.
I don't know much. Okay. Do you think because patient is a professional swimmer, would you allow the patient to go ahead in this condition for her tournament?
No, she has to. Yes, for at least 6 months. Yes, 6 months.
Yes. All right. Good. Thank you. Right. When you were doing, you did it very well. Now the feedback that I have to give you, some points that you have missed. You did it very well, very good, very good. But small things that you missed when you were palpating, you palpated for the temperature and tenderness, very good. At that time, if you would have taken the pulse, brachial and the radial pulses of both arms, that would have been good. And when you were doing movements, you did it very well, active and then passive. If you would have felt for the crepitus at that time, it would have been very good. And
for
then
what?
crepitus.
Crepitus,
yes. And then once you have done all the special tests, if you could have done the neurological examination of the sensory and motor examination of the axillary nerve and the motor examination of the long thoracic nerve by asking the patient to push against the wall, that would have been good. And that's all I had to add. And to complete your examination, definitely you have to examine one joint above and below, like cervical and the elbow joint.
Yes.
So that was the missing part. Yes, it was good. Thank you.